This video lecture is on nutrition for diseases of the kidneys. First and foremost, it's important to understand what do the kidneys actually do. If you understand how the kidneys work, it'll actually be quite easy to understand how we alter nutrition for when the kidneys are not working. So first and foremost, it's very important to understand that the kidneys are a filter. They filter about 1 liter of your blood every minute. So it's going to help filter out fluid and waste from the body through excretion. It's going to excrete those fluids when they're no longer needed. The kidneys help a lot with homeostasis, with your fluid and electrolyte balance. That's how a person normally gets rid of their electrolytes, like sodium, potassium, are key ones. It's also going to help with acid-base balance. Your kidneys manufacture hormones that affect blood pressure. That hormone, again, is renin. It's also going to stimulate production of red blood cells through erythropoietin, the hormone erythropoietin. It's also going to help activate vitamin D. And then lastly, it's going to help detoxify drugs and poisons by excreting them out of your body. So there are 2 types of renal failure, acute or chronic, and it's important to understand which one your patient has because that's going to change the diet therapy as well as their prognosis. So someone who has acute renal failure or acute kidney injury is going to see an abrupt loss of renal function. This is going to last less than a year and usually can be reversed. Someone who has chronic renal failure, this is going to be progressive. It's going to be irreversible, which means if you only have 50% of your kidney function, I'm never going to be able to get you back up to 75% of function. This is also called ESRF, which stands for end-stage renal failure, because there are different stages of renal failure. So possible treatments for either type of renal failure can be hemodialysis and peritoneal dialysis. If someone's having acute kidney failure, they're going to be put on this short term until the kidney function comes back. Somebody who has chronic kidney disease is going to need to continue on this therapy until death or until they have a kidney transplant, for example. Someone's nutritional needs are partly determined by whether dialysis is used for treatment. If, for example, they're getting hemodialysis, this is going to last 3 to 6 hours, and it's performed usually 3 times per week. It can be done outpatient, where they come into a hemodialysis clinic. Sodium and fluid may accumulate between hemodialysis treatments, which can lead to things like hypertension, edema, and heart failure. With peritoneal dialysis, either you get it 4 times a day, about for 30 minutes at a time, or we can see just overnight dialysis. Now, as you can see here in this picture, they use this thing called dialysate solution. There is dextrose in there. This needs to be actually calculated into a patient's energy needs. Therefore, peritoneal dialysis patients' energy requirements are less than someone getting hemodialysis. In addition, dextrose is a sugar, so patients who get peritoneal dialysis do have risk for hyperglycemia. I strongly encourage, if you want to learn more about hemodialysis, go and watch this video, as well as this video also talks about different types of treatment options. One other key thing to make sure your patients understand is that dialysis does not eliminate the need to comply with the prescribed diet. Some patients will say, oh, I can eat whatever I want now because I'll just go get it every other day when I go get my go to the hemodialysis center, they'll just take it off. That is a false statement. They need to really make sure they're watching their diet. And first of all, right here it says nutrition plays a critical role with managing these patients. The diet varies significantly based on what type of dialysis are they on. Do they have acute or chronic renal failure? What stage of chronic renal failure they're on? This is why we really use renal dietitians for this patient specifically. There are dietitians that are trained just and specializing in kidney disease. Another thing to think about is in acute renal failure is what is the underlying cause of that failure. They may be in a hypermetabolic state, like for example, if the acute renal failure is caused by a trauma, burns, or infection. And we have to take that into account in addition to the nutrient needs for the acute renal failure. This slide is just showing you a lot of other factors that influence nutrition status. And so you can see, like, for example, patients who feel early satiety or fullness, it's going to be patients who have those complaints are going to have different nutritional requirements. So this is just going through several different things. You're going to want to make sure you remember what interventions you can do, for example, if your patient is complaining of constipation, or what can we do for nausea. All right, so the first type we're going to talk about is called this pre-stage chronic kidney disease or pre-dialysis patient. This is when you're going to see your patient's serum creatinine levels elevated. That is a key lab that tells us about kidney function. We want this patient to avoid end-stage renal failure or kidney failure, so we're going to focus on dietary changes to decrease the risk factors for hyperglycemia and high blood pressure. By restricting protein, the kidneys don't have to work as hard. But if we restrict it too much, then lean muscle mass will be catabolized or broken down. We want to make sure that making sure the patient's getting enough high biologic value protein. We're going to restrict phosphorus because too much phosphorus can also cause deposits of calcium and phosphorus in the kidneys, and again make it harder for, or it's going to accelerate the kidney loss. And then lastly, by limiting sodium, we can help the patient have better blood pressure control. All right, so again, whether it is the chronic renal failure or kidney failure, or if they're actually in one of the different stages, we want to start the diet modifications early. Management really here is going to focus on slowing progression and minimizing complications. We don't want our patient to go into the next level if at all possible. There are many causes to chronic renal failure or kidney failure, but a big one is going to be diabetes. So if your patient has diabetes on top of end-stage renal failure, you're going to see how we're going to have even more education and more nutrition therapy to use. So again, the other thing too is this nitrous waste is going to start being retained because your kidneys are not working as well. So we're also going to see fluid retention and electrolyte imbalance here. So the treatment here is, there's different treatments. We can do conservative treatment, we can do dialysis, or we can do transplant. So I strongly encourage you to look in your books on page 456, table 21.1 for treatment and 21.2 for nutrition guidelines to see the differences between conservative versus dialysis, both hemodialysis versus peritoneal dialysis. But in general, there's going to be 4 things that we're going to restrict. We want to limit foods whose metabolic byproducts add to the buildup of toxic waste products. This buildup is also called uremic toxicity. It's going to cause your patient to have symptoms including the anorexia, the nausea, a metallic taste in their mouth, irritability, confusion, lethargy, restlessness, and pruritus or itchy skin. Excess fluid can lead to edema, hypertension, and heart failure. So we're going to talk about the 4 things that we're going to restrict. The first thing we're going to see that typically restricted is going to be fluids. Extra fluid can raise your blood pressure, which makes your heart work harder and increases stress during dialysis treatments. So you can see normally we restrict it to between about 1 and 1.5 liters per day, plus however much urine the person is making. So you can see in the example here, your patient makes 650 cc's of urine and they're on a 1 liter fluid restriction, which means they're allowed to get 1,650 milliliters a day of fluid. We're going to also monitor things like blood pressure, weight, and electrolytes because that will also play into how much fluid needs to be restricted or not. So specifically with the fluid restriction, we're going to want to teach our patients strategies to avoid thirst, as well as the risk for constipation. So review again, what are some things that we can help with thirst prevention? We've talked about like doing frequent mouth care, sucking on sugarless hard candies, using ice chips versus liquid, or even the use of a spray bottle versus a cup to limit fluid intake. For constipation, one other thing I want to say too is anything that melts at room temperature counts. So like Jell-O, popsicles, soup, and ice cream are all things that need to be included in that fluid restriction. All right, then you want to assess for constipation and think about how can you prevent constipation. In this patient, can we just say, oh, drink more fluids? Also, the other thing to think about is most fruits and vegetables are going to be high in potassium. So we want to encourage insoluble fiber foods that are not going to be high in potassium or other things that we're going to restrict. All right, so with fluid restriction, there's going to be weighing. Body weight is measured daily at the same time each morning and recorded. We want them to have like the similar types of clothing on, as well as a similar time of day. Also, before and after each dialysis treatment, we're going to want to weigh that patient and document it in kilograms usually. For fluid balance, we're going to be looking really at their weights. That's why, again, weight needs to be done at least daily. It's actually going to be done at least twice on dialysis days, because if we see weight loss around half a kilogram or less in one day, that really means that they're not eating nutrition the way they have undernutrition. But if we see weight loss or weight gain of more than half a kilogram a day, that's really going to indicate fluid loss or fluid gain. All right, the second thing we're going to restrict here is going to be potassium. Many dialysis patients experience hyperkalemia or high potassium. So we're going to want to teach our patients foods that are high in potassium. There's even a nice table in your book, as well as those salt substitutes and the sugar substitute that has, alternative sweetener that has acetylsulfame K. That K stands for potassium. We're going to monitor their lab values closely to make sure that they do not become hyperkalemic. There is some things, for example, we could teach our patients like peeling potatoes, because most of the potassium is in the peel, is one way that we can take an item and make that is high in potassium and lower the content. The third thing we're going to restrict is going to be sodium. We want to definitely teach our patients to avoid high sodium foods, not to add salt to their food. Remember, most of the sodium in the American diet comes from processed foods, fast foods, frozen dinners. But then other things that a patient might not think about, like pickles or salad dressing, ketchup, soy sauce, MSG, which is monosodium glutamate, cheese, are all going to be high in sodium, so we're going to want to limit those. Then the last thing we're going to restrict is going to be phosphorus. As your renal failure develops, fewer nephrons are available to excrete dietary phosphorus, and so the plasma phosphorus levels in your patient will rise. It is recommended that dietary phosphorus be restricted to less than 1,000 to 1,200 milligrams a day. You will not need to know that specific number. The use of phosphate binding medications with all food intake is required to achieve this goal. So you can see here, for example, Phoslo, Renagel is the big one I see, or Tums are the two big ones that we typically use. These are going to bind with the phosphorus in their food, so it's going to lower the bioavailability, and so it's going to not be absorbed or lower absorption. Because we're trying to prevent renal bone disease and hyperparathyroidism. So obviously with every meal as well as snacks, you're going to have to take them. They do take different amounts depending on how high of a phosphorus meal they're having. So once again, issue here is foods that are usually high in phosphorus are also high in calcium. So milk and milk products, for example, cheese, which we need to limit because of their high phosphorus content, we're going to have concern with how we're going to get that calcium in. You can also see things like soda, legumes, nuts also are high in phosphorus, so we're going to need to limit them. Actually, patients with chronic renal failure should be limiting their milk to half a cup per day. All right, so we talked about what we restricted. Now let's talk about what we need to make sure they're getting enough of. So vitamins and minerals may be missing from the diet due to these restrictions. So they need to take a special multivitamin. They cannot just take any one found on the shelf. They actually take these special ones called like NephroCaps or NephroTabs. Nephro, hopefully you recognize as being kidney. So these are special multivitamins for someone who's on hemodialysis or who has kidney failure. These are not going to have vitamin D because they need to actually take the active form of vitamin D, because again the kidney's not going to be able to activate it. These should be taken after treatment, after dialysis, so they are not just dialysizing it off. Calcium supplements. So I do not like to use supplements. This class is not just how to take a supplement, but in this patient population, it is going to be really hard to get enough calcium in without supplementing. So we're going to use either oral, like PO, or IV calcium supplements. They're often necessary in order to get enough calcium in without getting too much phosphorus. And then the next one, we'll start with iron supplementation.